As Pejman mentioned, I'm Daliya Ignatius, and thanks for coming to my final master's presentation. I'm a Master of Medical Physics student at the University of Western Australia, and this is my final semester. And the title of my study is Evaluation of Radiotherapy Treatment Planning of Spine and Pelvis using Single Energy Metal Artifact Corrected CT Images. And before I begin, I would like to introduce my research supervisors, Associate Professor Mahsheet Sabet, Mr. Zaid Alkhatib, Dr. Pejman Rowshan Farzad, Mr. Simon Goodall, and Dr. Mounir Ibrahim. So a quick introduction into external beam radiation therapy. As you all know, in EBRT, after diagnosis of cancer, a patient undergoes imaging using a CT simulator. And CT is an X-ray modality, and imaging is dependent on the attenuation of X-rays passing through the patient's body. And these CT images are crucial in the next steps of the treatment flow because contouring of the target volumes and the organs at risk are performed on these CT images. And for treatment planning and dose calculation, we use the CT numbers in Hounsfield Units from the CT images to determine the relative electron densities, and any incorrect assignment of these values could result in dose calculation errors. And one source of such error is metal implants. And these are very common and include things like metallic screws or rods, knee, hip, and shoulder prostheses, stents and vessel clips, dental fillings, and cardiac pacemakers. And CT scanning through these high-density objects can result in errors during image reconstruction, which appears as bright and or dark streaking artifacts, as shown here. And these metal artifacts are caused by photon starvation, beam hardening, scatter, noise, and exponential edge gradient effect. And the degree of this artifact actually depends on several intrinsic and technical factors, such as the X-relative potential, the MAS, the type, shape, and size, and also the orientation of the metal with respect to the scan plane. And in terms of application to radiotherapy, a problem with these metal artifacts is that they affect the CT numbers and also the accuracy in contour delineation. And what then happens is that these incorrect CT numbers can produce incorrect RED, which then cause errors in the subsequent dose calculation. And so one way to tackle these metal artifacts is by using metal artifact reduction algorithms. And there are several commercially available MAR algorithms currently available, and one algorithm that uses sinogram in painting technique with iterative reconstruction is the Single Energy Metal Artifact Reduction, or SEMER, by Canon Medical Systems, previously known as Toshiba American Medical Systems. And this algorithm uses iterative reconstruction technique where the metal is extracted from the original CT image to create a sinogram of the metal-only image as shown here. And the original sinogram is then subtracted from the metal-only sinogram, which then creates a metal-free sinogram using interpolation. And this creates a final image by blending the reconstructed image with the metal image. And here is an example comparing the CT datasets reconstructed with and without SEMER. And we can easily see that the one with SEMER greatly reduces the metal artifacts. And in terms of publications, there are numerous research papers published in diagnostic imaging on the efficiency of SEMER algorithm in reducing metal artifacts on CT images. And shown here are just a few of those. But the dosimetric accuracy of SEMER was studied only 3 times. Once in EBRT by Murasaki et al. Using unilateral and bilateral metal inserts, and once in carbon ion radiotherapy by Mickey et al. Using an anthropomorphic head phantom with metal screws and patient data, and once in brachytherapy by Shirashi et al. For iodine 125 seed identification for prostate brachy. And the main results for these studies are shown here, where all 3 studies showed improvements in CT number prediction and dose calculation accuracy. And since our project focused on the dosimetric efficiency of SEMER in EBRT, our main reference is the Murasaki et al. Study. And this study, however, has 2 major limitations. One is that the densities of the artifacts with regions with artifacts were not overridden for dose calculation. And secondly, the results were not compared to the measured dose. And so our study improved on these limitations by using phantom and patient CT data with metal implants, replicating two clinical regions. And for dose calculation, dose comparison, the RAD values of the artifact regions on the CT dataset without the Semmer filter were contoured and overridden. And the dose calculated on the CT datasets with and without the Semmer filter were compared using dose volume histogram, and the dose measurements were performed in the phantoms using film and ionization chamber. And so the aim of the study is to analyze the effects of Semmer and to determine its clinical suitability for EBRT treatment planning by assessing the accuracy of Semmer in CT number prediction and dose calculation in spine and in pelvic regions. And this is important because currently in many radiotherapy centers, when developing a treatment plan on a CT dataset with metal artifacts, Semmer is used as a reviewing tool only. And this is performed to avoid misinterpreting metal artifacts during contouring. And this method, however, has limitations, including the need for artifacts to be manually contoured on individual CT slices, which requires longer time and also introduces subjectivity. Also, forcing soft tissue density to artifact-affected regions may not be accurate if the true CT numbers are known, which introduces systematic uncertainty. So moving on to the materials and methods now. In terms of the materials, we study the effects of Semmer on two in-house 3D printed humanoid phantoms and CT data of two patients retrospectively. And here is the first phantom, which replicated the spinal region. And this phantom was constructed for a previous study, but used for this study. And this phantom had 8 modules, including 3 PLA-only body modules, 6 dual-printed spine modules with a fixed film holder, as shown here, and 1 dual ionization chamber, as shown in this diagram here. And 2 such phantoms were constructed, one with titanium screw inserted and the other with no metal inserts. And more information about the design and printing of this phantom is available in the Goodall et al. Paper published in 2021. And the second phantom, which is constructed purely for this study, replicated the pelvic region. And shown here are just a few photos on the phantom construction. And all parts of the phantom were 3D printed at Charles Guyana Hospital. And again, 2 phantoms were constructed, one with titanium rod in place of a femoral bone, and the other phantom with no titanium or no metal inserts. And the organs were filled with different mixtures of uracil, gelatin, sugar, flour, and water. And once these were set, the organs were glued in place, and later the phantom was filled with a mixture of gelatin and water to prevent any leakage during imaging and treatment delivery, as shown here. And once the gelatin was set, the phantoms were sealed and ready for imaging. And so we CT scanned the 2 phantoms, generating 3 datasets for each type. The one without metal, named CT Ref, was our reference phantom, and the one reconstructed with and without Semmer. And the metal artifacts on the CT data with Semmer were corrected by the algorithm, whereas metal artifacts on the CT datasets without Semmer were corrected by manual overriding with water. And for the retrospective patient study, the CT datasets of 2 patients with metal hip implants were selected. And this slide is very important because for the rest of the presentation, I'll be referring to this naming convention. And so then using these data sets, the CT number accuracy and dosimetric accuracy of Semmer was studied. So CT number accuracy was determined by the mean HU values on 8 cylindrical regions of interest, volumes of interest, covering 5 most artifact affected slices, avoiding the metal inserts. And I'll show you an image of this in the next slide. And the dosimetric accuracy was determined by comparing the dose calculated using DVH analysis and dose measured using film for the spine phantom and ion chamber for the hip phantom. So just to make it clear, here are screenshots of the spine phantom CT datasets on the Eclipse TPS. And on the left is the reference phantom with no artifact correction, as it didn't have any metal inserts. And middle is the one with metal, where artifacts were corrected using the traditional method of manual density override. And on the right here is the scan of the phantom with metal, but reconstructed with the Semmer filter. And so that's a method. And now moving on to the results and the discussion. The graph shown here is the CT number for 8 VOIs positioned within the spine phantom, avoiding the titanium screws as shown in the schematic at the top left corner. And based on this, the absolute mean CT number difference between the reference CT dataset and the one with Semmer, i.e. the black and the gray bars, was 12.8. Similarly, for the reference versus no Semmer, i.e. the black and the white bars, the mean CT number was 36.3. So looking at the values here, we can see that correcting artifacts with Semmer filter generates CT numbers that are closer to the corresponding metal-free CT scan, which in this case is our reference. And these results were evaluated using the root mean square deviation, and the differences were observed to be statistically significant. And the RMSD difference between CT ref and CT Semmer was 29.1, whereas that between CT ref and CT no Semmer was 64.5. And similarly for the hip phantom, shown here is the graph of the CT numbers for 8 volumes of interest positioned within the hip phantom, avoiding the titanium rod shown in gray in the schematic here. And here, the absolute mean CT number difference between the reference and one with Semmer was 3.1, while that between the reference and no Semmer was 23.7. Again, just like the spine phantom, looking at the values, you can see that artifact correction with Semmer generates more accurate CT numbers. And the RMSD between CT ref and CT Semmer was around 6 times better, and the value was 19.3 in comparison to the RMSD between CT ref and CT no Semmer of 118.1. So moving on to the dosimetric accuracy of Semmer, the graph shown here is a DVH analysis of the spine phantom. And it is based on the plan shown here, where on the left is the plan with manual density overrides, i.e. without Semmer, and on the plan and on the screenshot shown on the right is a plan with Semmer, so no overrides. And based on this DVH analysis, the percentage difference in dose distribution between CT spine Semmer and CT spine no Semmer for PTV D5 was 0.03%. For PTV D50, it was 0.18%, and PTV D95 was 1.1%. And the dose calculated on the dataset with Semmer and the dataset without Semmer shows near identical dose distributions with clinically negligible dose difference. So moving on to the hip phantom now, the PTV included the ion chamber and a small part of the metal as shown here. And so it's similar. So this replicated the scenario of patients with PTV, including their metal implant, which can occur in clinical practice. So similar to the spine phantom, the same was observed for the hip phantom, where the percentage difference here in dose distribution, so percentage difference in dose distribution between hip Semmer and hip no Semmer for PTV D2 was 0.19%, while that for D50 was 0.17% and D95 was 0.31%. And here is the retrospective patient study data, and the DVH shown here is for a male patient with bilateral prosthetic hip with PTV in the prostate. And again, we can see identical dose distributions between the two artifact correction methods. And the percentage difference in dose calculation for PTV D5 was 0.02%, while that for D50 was 0.01%, and for PTV D95 was 0.11%. And likewise, the deviate shown here is for a female patient with unilateral prosthetic hip with PTV in the bladder. And here, both the PTV dose to 5% and 95% of the volume showed a percentage difference in dose distribution of minus 0.21% between the two plants, and the PTV D50 was 0.31%. And except for this patient with the unilateral prosthetic hip, results from all the other DVH analysis just shown indicate an improvement in dose calculation when the SEMR filter was applied to the CD datasets with metal artifacts. So now moving on to the dose results of the dose measurements. For the spine phantom, dose measurement was performed using gaphchromic film and shown here. And screenshot here is the 2D gamma analysis comparing the film measured dose distributions. And from the gamma passing rates shown here, the difference between the CT datasets was 1.4% for the 3% 2 mil, and 2% for 2% 2 mil, and 1.2% for 1% 1 mil. And these results indicate an improvement in the passing rate when SEMR filter is applied to CD datasets with metal artifacts as we expected. And on the hip phantom, point dose measurement was performed using a CCO4 chamber. And on this image, you can see the positioning of the chamber with respect to the metal insert. So we created a plan and delivered it to the metal, which is measured in, which is the measured dose shown here in gray. And the TPS calculated dose obviously was different for the two data sets shown here. And the TPS calculate, and so the average point dose measured was 1.92 gray, and the calculated doses for hip SEMR was 1.88 gray, and for hip nose SEMR was 1.87 gray. And from that, we got the relative percentage dose difference between the calculated and the measured doses to be minus 2.0% for the hip SEMR and minus 2.5% for the hip nose SEMR. And this is all the results. But prior to constructing the more sophisticated spine of the hip phantoms, measurements were done on the standard electron density phantom by SIRS. And I took measurements using this phantom on 3 CT scanners from 3 different vendors, and each had different MAR algorithm. So we scanned it at Sir Charles Gardner Hospital, Genesis Care, and Icon, but considering the time frame of this project, we decided to just stick with the SEMR algorithm. But I'll show you the results of SEMR just for this phantom really quickly. So in terms of method, it was the same as that for the other 2 phantoms, but for this phantom, we had 3 scenarios. So no metal insert scenario labeled A, unilateral titanium rod insert scenario in B, and the bilateral titanium rod insert scenario in C. And these phantoms were scanned, and using ImageJ software, the mean CT numbers were measured on 3 contiguous slices of the center region of the phantom. And we used circular VOI of a fixed diameter, and the CT number difference was then calculated by subtracting the CT number obtained without any metal inserts from that with metal inserts corrected with and without the SEMR filter. And so for the unilateral metal insert scenario, the CT number difference is shown here. And for the bilateral metal insert scenario, you can see here bilateral, the difference is shown in this graph here for all the different tissue equivalent inserts. And we concluded that except for a few tissue equivalent inserts, the results show that SEMR correction improves the CT number accuracy for both the unilateral and bilateral metal insert scenarios. So based on all these results, we conclude that SEMR algorithm is successful in reducing metal artifacts and restoring CT numbers in the tested regions. And semi-corrected CT plan is comparable with the plan on CT with manual density overrides, with agreement between the measured and the calculated dose distributions. And incorporation of SEMR into EBRT planning workflow can save time in contouring and also avoid subjectivity in overriding any artifacts. And SEMR is also adapted to clinical applications, as Pejman said, at such as Gardner Hospital in Perth, where dose is calculated on the SEMR-corrected CT images in external beam radiation therapy for lesions in spinal and pelvic regions. And so for future work, SEMR requires further testing with a variety of metal implants and patient scenarios. And I think it should include other most used metal implants, including stainless steel and chrome cobalt, since they produce more artifacts than titanium, which is what we used at equal energies. And because this study only focused on spine and pelvic regions, in future study, we would like to study, like if we were to repeat this or continue this in the future, we would like to study patients of different clinical sites with different types, shapes, and sizes of metal implants. And also another study to conduct will be to compare SEMR with metal artifact correction using deep learning and see if there is any difference, and if so, by how much. And also thanks to Mahsheet, Zabet, who applied for ethics approval for the study, and no formal consent was needed for the study. And in terms of conflict of interest, we have nothing to disclose. Also, the manuscript of this research has been published, so has been submitted to the Medical Physics Journal. And I would like to extend my gratitude to the medical physics team in Perth at Sir Charles Gardner Hospital, Genesis Care, Icon Cancer Centre, and the University of Western Australia for their guidance and resources during this study. Also, huge thanks to Andrew Hurst and Riley Croxford for designing and constructing the hip phantom. And heaps of thanks to Gabor Naveri for advice and help with CT scanning the phantoms. And finally, I would like to thank my supervisors for their continued support and guidance throughout this project. And without them, this project would not have been worth publishing. And thank you so much for making this whole journey a truly enjoyable one for me. And here is the list of references that I used. And thank you for listening.
Great. Thanks very much, Daliya. Really.
Thanks, Pejman.
Brilliant. Excellent. So good timing as well. So any questions from Daliya? No question. All good.
I have some questions.
Martin. Sure.
It's a terrific
Yes,
presentation.
please, go ahead.
Thanks, Daliya. The prostate case you showed, I think they were all VMAT treatments, is that right?
Yeah.
Yeah. So remember in the past we used to treat with a 4-field treatment and two beams laterally through the hips. And if there was metal there, they would actually change the angles, which impacted the dosimetry. Do you think that CMAR would have helped in that situation? Because in that case, you're not spreading the dose over such a large area as you are in VMAT. You have a bigger effect through the metal. Would it have helped in that situation, do you think?
Because we found the dose distribution to be the same with and without, I wouldn't think it would, with manual override, I would think it would be the same.
Mm-hmm. Yeah, okay. Right, and just another question.
Sure.
The 2.5% impact that you found in the spinal case, what do you think the sort of ramifications are for that much dose difference?
Oh, it's just clinically insignificant dose difference. That's what we have concluded, but it just showed to us that they're like doing it with manual override, which is our traditional method, and doing it with CMR is just almost same. It's comparable, which is what the conclusion was from our study. So we were happy with that. It didn't show that using simmer produced a better result. It just showed that they were both comparable. So why not use the one with simmer, because it saves time, it doesn't introduce subjectivity, it's just overall better and cost effective as well.
Sure. If someone else has a question, they could jump in. Otherwise, I've got one more.
No worries, go ahead, Martin.
The impact on dosimetry, which is certainly important. What about the impact on actually identifying anatomy and performing segmentation, for example? What's the impact there? Can CMAR actually help with that, or is it really only going to help for dosimetry?
I don't know, like that's what I showed. Like there are lots of papers on the diagnostic imaging side of CMAR that shows that CMAR actually better identifies structures, and it's just easier to see structures, the organs at risk with CMAR filter. So it overall makes the actual CT scan better to visualize. But that was like a diagnostic imaging side. That's why we focused on the dosimetric side.
Sure. Yep, that's fine. Thanks.
Thanks, Martin.
Thanks, Martin. So,
Daliya,
Mahsheet, you want to say?
that's wonderful presentation and great work. You did work really hard, and you were so well organized. I'm really impressed by your organization skills. Would you have done anything differently if you were to do this again?
Given the time frame, maybe not. But as I said, if I'm to continue with this in the future, deep learning would be something that I would consider, or just because deep learning is something that's emerging. So rather than comparing SIMR with the other commercially available algorithms, I would like to compare it with deep learning and see how we can implement that into clinical practice.
Great, thank you.
Which is a PhD project.
Yeah, that's why it's a future work.
That's right. That's good one. So any other questions from Daliya? So all good? No questions?
Great work, Daliya. Great work. Thank you, Daliya. Well done.
Thanks, Zaid. Thanks so much for your help though throughout.
Yeah, very well done, Daliya.
Thanks, Mounir.
Brilliant. Thanks very much, Daliya. We stop recording.
Sure. Thank you.